Yeah. Yeah, 5 minutes. Yeah, Dr. Partha, you can share your slides.
No. Hello. Hello.
Hello. Hi,
Can
on
you
this
hear
side.
me?
Yeah,
Hi. Yeah.
I can hear you. Yeah.
So, very good evening, everybody. I am. Yeah.
Sir, just a minute.
Yeah.
He will give the 1, 2, 3 cue so that the recording will begin. Yeah.
Okay. Very good evening, everybody. I am Dr. Animesh Maiti, currently attached in the Department of Endocrinology Medical College as head of the department. On behalf of our endocrine department, I welcome you all on board. And we are really privileged to have with us our respected sir, Professor Subhankar Chaudhary sir, who is a stalwart in the field of endocrinology. Also, we have with us galaxy of bright young endocrinologists, Dr. Pranab Kumar Sahana, who is attached with NRS Medical College in the Department of Endocrinology, Dr. Arjun Vaidya, Dr. Soumik Goswami, Dr. Rana Bhattacharya, Dr. Anirban Sinha, Dr. Parthapatim Chakraborty, Dr. Parthasarathi Chaudhary, Dr. Shubhishar. So initially we will have 2 lectures, 30 minutes each. And after each lectures, there will be short question and answer session. So everybody is requested to put their question in the chat box. And after the end of each lecture, there will be a short discussions, which will be taken up by the chairpersons. And after the 2 lectures, there will be panel discussions. So without much delay, I will invite Dr. Pranab Sahana, who is an associate professor and attached in the Department of Endocrinology, NRS Medical College, and who has got many publications, both national and international journals. Over to Dr. Pranab Sahana.
Thank you, Dr. Maiti, for your kind words. And good evening, everybody, once again to all of you. So, first of all, I want to thank Dr. Maiti for inviting me as his chairperson in this nice CME. The theme is the growth hormone update. So, first topic is genetic diagnosis and management of Prader-Willi syndrome. As you all know, Prader-Willi syndrome is a genetic disease which can manifest with a wide range of symptoms and signs. And though 2 main features of this syndrome is, one is obesity and another is short stature. And it is one of the important indication of growth hormone therapy. And we have seen that growth hormone therapy can improve many features of Prader-Willi syndrome apart from growth matters. So in this context, I want to invite Dr. Parthapatim Chakraborty, who is an astute endocrinologist as well as clinical tutor attached to Medical College, Calcutta. So, Partho, please start your lecture.
Thank you, Pranabda. Very good evening to all of you. Is my screen visible?
Yes.
Yes.
Hello.
Yes, it's visible.
Okay. So Prader-Willi syndrome is the most common cause of syndromic obesity, with an estimated prevalence of 1 in 25,000 birth and a population prevalence of 1 in 50,000. Because of the topic I am assigned to, I shall not spend much time on the clinical features. However, unlike many other syndromes, Prader-Willi syndrome is much more easier to diagnose because of the characteristic clinical features. For an example, I came across this boy yesterday only in my endocrine clinic at Medical College, Kolkata, with the typical features of Prader-Willi syndrome. Now, the clinical manifestations depend upon age of presentation, and I have underlined those which I personally rely upon For an example, maybe a decreased fetal movement, a history obtained from the mother, hypotonia, decreased movement, poor sac, cryptorchidism in neonates, intellectual or learning disabilities, hyperphagia, progressive obesity, short stature in childhood, and hypogonadism, both hypogonadotropic hypogonadism and hypergonadotropic hypogonadism, obesity-related complications, different behavioral issues, and food-seeking behaviors in adolescence. Now, for the trainees, many of them may present with premature adrenarche, puberc, or even premature puberty, because we all know that inactivating mutation of the MKRN3 is associated with central precocious puberty, and MKRN3 probably lie in the critical Prader-Willi region. Now, I have kept this slide for two purposes. Number one, weight gain associated with Prader-Willi syndrome is usually obvious after 2 years of age, the so-called phase 2A of the disease, and clinically significant hyperphagia is obvious after 8 years of age, the so-called phase 3 of the disease. To make our life even more complicated and to test our memory function, a clinical diagnostic criteria was established back in 1993. However, in this era, where widespread availability of various genetic analyses are available, this diagnostic criteria perhaps is not clinically relevant. Now, Prader-Willi syndrome is a typical example of genetic imprinting, meaning thereby some gene of a chromosome is active while others are inactive depending on the parental origin. Though we now know the critical Prader-Willi region is in the long arm of chromosome number 15, 15q11 to q13 to be more specific. However, the number of genes or the specific putative genes are yet to be identified, and there are a whole number of suspected abnormal genes, of which SNRPN is probably the most important one, and the other important genes I have highlighted. Prader-Willi syndrome and Angelman syndrome are called the sister syndromes. In Prader-Willi syndrome, the genes of the paternal origin does not function properly, and the reverse happens in Angelman syndrome, where genes of the maternal origin have improper function. Focusing on genetics, if you look at the chromosome P, chromosome 15, Q11 to Q13, in normal individuals, the genes obtained from the father are unmethylated, hence active, while genes from the mother are methylated, hence inactive. Now, there are three main forms of Prader-Willi syndrome, the commonest being paternal deletion of 15q11 to q13. The second most common is maternal uniparental disomy, that involves about 25% of Prader-Willi syndrome. And the next common cause is an imprinting center mutation. The imprinting center is also situated within the critical Prader-Willi region, and it regulates the unmethylation of the paternal chromosome. So if that center gets mutated, that unmethylation of the paternally inherited chromosomes do not happen, so they are inactive. So these are the three main forms of Prader-Willi syndrome. Now, I am a bit poor in genetics and probably worst in statistics. And the people I am closely associated with. For an example, I can see Dr. Rana Bhattacharya in the audience. He always laughs at me whenever I refer to this slide. But believe me, this is the most simplest overview of the genetic tests we advise in endocrine practice. For the whole chromosome analysis, we do karyotype. And if time is a constraint, we do quantitative fluorescent PCR for picking up aneuploidies. For submicroscopic deletions, for an example, those deletions with less than 5 megabase in size, if the position is known, we rely on FIS or MLPA. And if the position of the deletion is not known, then we have to scan the whole genome by ACGH or the array comparative genomic hybridization. And for point mutations, we rely on DNA sequencing either by Sanger's or next generation sequencing or ARMS. Now, I shall be repeating FIS or MLPA in the course of my talk because we know the critical Prader-Willi region is situated between 15q11 and 15q13. So what are the diagnostic tests available for Prader-Willi syndrome? We can opt for a very high resolution chromosome analysis. However, as I have said earlier, it only detects large deletions more than 5 megabase in size. It is of no use for small deletion, uniparental maternal disomy, or imprinting mutations. The FIS is the widely available or the most commonly advised test for Prader-Willi syndrome. Once again, it has its own drawbacks. For an example, it cannot detect uniparental maternal disomy. It cannot detect imprinting mutations, and it can only detect that there is a deletion. However, it cannot differentiate whether the deletion is lying in the maternal chromosome or paternal chromosome, meaning thereby it cannot differentiate Prader-Willi syndrome from Angelman syndrome. So you have to correlate the findings of FIS from the clinic with the clinical features. The other tests which are done in Prader-Willi syndrome are the different DNA methylation tests, or as a substitute of DNA methylation test, the RNA expression test done by RT-PCR. They cannot differentiate deletion. They cannot identify uniparental maternal disomy or imprinting mutations. The other test that is available is DNA polymorphism studies to confirm uniparental disomy, and it requires samples from both parents and the patient. So with the diagnostic algorithm. Now, if there is a very high clinical suspicion of Prader-Willi syndrome, you may rely on FIS as a first line test because 70% of Prader-Willi syndrome is because of deletion. If you get a positive FIS, you know the Prader-Willi syndrome is because of deletion. Now, if the FIS is negative, then you do a DNA methylation test or a RNA expression studies. If you get a positive result, that means the cause of Prader-Willi syndrome is either uniparental maternal disomy or imprinting mutation because you have ruled out deletion by FIS in step 1. So to differentiate uniparental maternal disomy and imprinting mutations, you need to rely on the DNA polymorphism studies. If you get a positive DNA polymorphism studies, the etiology is uniparental maternal disomy. If you get a negative DNA polymorphism study, that means the defect is in the imprinting center. Meaning thereby, an imprinting center mutation, which is the least common cause of Prader-Willi syndrome, is basically diagnosed by exclusion. For an example, the 17-year-old boy, very strong of Prader-Willi syndrome, history of hyperphagia, significant weight gain, hypogonadism. The test would be a FIS. And we detected that there was a deletion 15q and 15q13. So on the background of a typical clinic feature, the diagnosis of Prader-Willi syndrome was established. Is another 7-year-old girl with progressive weight gain, history of hyperphagia, mentally retarded, new onset diabetes. Once again,
Partha, you are muted now.
Partha has probably disconnected.
না আছে, দেখা যাচ্ছে আনমিউটও করেছে।
লাস্ট পর্যন্ত কি শোনা গেল? মানে আমি যা বললাম?
না, সেকেন্ড কেসটা শুরুতে, ফার্স্ট কেসটা অবধি শোনা গেছে, সেকেন্ড কেস
ওকে 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 দাঁড়াও। Am I audible?
Yes.
Okay.
Also visible. Slides are visible. Okay.
Okay. So once again, the clinical suspicion was high. The fees was advised, but fees came negative. So what should be the next test? You advise a DNA methylation study, and that came positive. So once, if the fees is negative, you advise the methylation test, it came positive, confirming the diagnosis of Prader-Willi syndrome. So for the next test would be a DNA polymorphism study to differentiate uniparental maternal disomy from imprinting center mutation. However, we did not have access to that study. Now, what do you do if the diagnostic algorithm, if the clinical suspicion is low? You may use the DNA methylation test or the RNA expression test because it has a very high sensitivity with an accuracy of around 99%. If this is positive, you do a FIS to identify deletion. If the FIS is negative, once again, you rely upon the DNA polymorphism study. If that comes positive, your diagnosis is uniparental maternal disomy. If that is negative, the defect is in the imprinting center. For an example, this boy presented with obesity. The clinical suspicion of Prader-Willi syndrome was low. So a DNA methylation study was advised, not FIS. And as you can see, this is not a report from that. This is the left side. The report was from this particular child. And the report came out to be positive, suggesting methylated DNA in the 15q11 or 15q13. The other alternative of DNA methylation test is a methylation specific MLPA, as shown in case Y, which I shall be discussing later on. Now, some of the labs I am associated with, particularly in outside Kolkata, they do not do a DNA methylation study, and the fees is somewhat costly. So they do an RNA expression studies as an alternative to DNA methylation test. And what is the background of this RNA expression test? They detect the gene expression, often using an SNRPN probe. If the DNA is methylated, the genes are inactive, so there is no protein expression. So if you get no protein expression on a background of suspected Prader-Willi, that suggests methylated DNA in that particular region, confirming a diagnosis of Prader-Willi syndrome. However, on the other hand, if the SNRPN expressions are there, it effectively rules out Prader-Willi syndrome in that particular patient. Now, this was diagnosed on the basis of methylation specific MLPA. Now, if you look at the right hand side, the report stated that deletion identified in the chromosome 15q11 to 15q13. So a methylation specific MLPA has an advantage of identifying deletion in addition to the methylation pattern of the DNA. The methylation specific MLPA detects not only average copy number, but methylation status of the target sequences. So if you get all the DNAs are methylated, you know there is no paternally inherited active gene. So your diagnosis of PWS or Prader-Willi syndrome on a clinical background is confirmed. Now you look at the then copy number. If the copy number is less than expected, you suspect deletion. If the copy number is normal, then you suspect either uniparental maternal disomy or an imprinting mutation. So MS-MLPA has an advantage of a combination of FIS and DNA methylation studies. More importantly, perhaps, we can do this test free of cost from the genetic services unit of the PG Polyclinic. Now, if the clinical suspicion of Prader-Willi syndrome is low, you have performed methylation specific MLPA or a methylation study or an RNA expression study, and that comes negative. Then you need to consider a condition known as hyperphagic short stature. Now, hyperphagic short stature and Prader-Willi syndrome, they share many clinical signs and symptoms. For an example, both of them may have hyperphagia, failure to thrive, hypotonia, short stature, lung difficulties, skin picking, and so on. However, the most differentiating point is obesity, which is uncommon in hyperphagic short stature and another a particular form of psychosocial dwarfism. There is a diagnostic criteria of hyperphagic short stature, so you cannot rely upon any particular test, be it biochemical, be it genetic, to diagnose hyperphagic short stature. So if you are suspecting Prader-Willi syndrome and the genetic tests are negative, you think of this and you look at the diagnostic criteria for confirmation of diagnosis. Now, the next common question that are going to be asked by the parents are the risk of Prader-Willi syndrome in the subsequent pregnancies. The risk is low because the Prader-Willi syndrome happens by chance. For deletion and for uniparental maternal disomy is less than 1%. Uniparental maternal disomy is basically seen, more commonly seen in elderly mother. However, if the defect is because of imprinting mutation, the recurrence is almost 50% like that of an autosomal dominant inheritance. Now, as the father is asymptomatic, he had received that mutation from his mother, but he is able to transmit that particular mutation to his boy with an estimated risk of 50%. The risk is much higher if the defect is in, if the etiology of Prader-Willi syndrome is balanced chromosome translocation. So once the diagnosis is made, you need to treat, you need to evaluate for something. The textbook, the traditional textbook teaching has been that almost 60% of Prader-Willi syndrome patients have central hypoadrenalism. They have both primary and secondary. However, primary hypogonadism is much more commoner than secondary hypogonadism. And the typical biochemical characteristic is low LH, low inhibin B, and high FSH. Almost quarter of a patient have central hypothyroidism, but because of obesity, the TSH may be high in some of those children. You need to do the DEXA you need to look at the Z score if you have that data with your machine starting from 5 years of age, and that to be repeated every 2 to 3 years. You all know that they are at high risk of type 2 diabetes, atherogenic dyslipidemia, non-alcoholic fatty liver disease. But the most important thing perhaps is sleep apnea, which is encountered in about 70% of those individuals, and sleep apnea can be obstructive and non-obstructive. Scoliosis probably is not that important. However, you can get radiological evidence of scoliosis in almost 80% of them, and all 20 to 40% of them are clinically significant. If you are interested in other questions, you will look at the resting energy expenditure, which is one of the commonest, which is the main underlying cause of obesity in these patients, and the resting energy expenditure is almost 60% of that normal. The ghrelin level is massively elevated, and all of them should undergo a formal IQ testing, and the usual IQ lies in the range of 70. Many of them may have normal IQ, but despite having normal IQ, they often have learning disabilities. Now, as I said, basic textbook teaching has been almost 60% of them have central adrenal insufficiency. But if you look at the recent evidences, this is a paper published in JCM this year. The prevalence of central adrenal insufficiency in adult is around 1.2%. Now, I searched literature and found that any publications done in 2011 or 2010, the prevalence of central adrenal insufficiency as detected by low-dose synecthen test or a high-dose synecthen test or an insulin tolerance test, both in children and adults, are not very high. Even majority of them have normal hypothalamo-pituitary adrenal axis. So, meaning thereby, you need to evaluate for central adrenal insufficiency, perhaps in those adults with features suggestive of adrenal insufficiency. Coming to the most important hormonal axis, that is the growth hormone IGF-1 axis. Growth hormone deficiency probably in seen majority of patients of Prader-Willi syndrome, if not all. However, evaluation perhaps is not necessary unless there is growth failure. Interestingly, those with maternal uniparental disomy have less growth hormone secretion compared to those with deletions. Now, if you look at the indications of recombinant human growth hormone, the indication is not Prader-Willi syndrome. It's not like Turner syndrome. You diagnose Turner syndrome, you give growth hormone. Giving growth hormone to Prader-Willi syndrome, you need to document growth failure. So formal testing in absence of growth failure may assist in early initiation of growth hormone, but this is not, at least not an US FDA approved indications of growth hormone therapy in Prader-Willi syndrome. While testing for growth hormone stimulation test, you have to be a bit cautious because of obesity itself can give rise to low growth hormone during stimulation tests. Now, while giving growth hormone, you target IGF-1 and IGF-BP3, and your target should be upper half of the normal range for age. This I yesterday, confirmed of Prader-Willi syndrome by FIS. Now you look at the growth chart. It's relatively larger than the target height. So do we need to give growth hormone, or do we need to do a formal testing growth hormone? I did not do that, and would like to have opinion from our faculties today what to do with growth as far as growth hormone testing is concerned and treatment is concerned in these patients with Prader-Willi syndrome. We have kind of growth charts
Hello, Patto. Are you able to join the growth chart? এই কেসটা growth chart যা শুরু করেছিস।
এটা গ্রোথ চার্ট শুনতে পেয়েছো? গ্রোথ চার্ট শুনতে
না,
পেয়েছো?
গ্রোথ চার্টে শুনতে পেয়েছি কিন্তু দেখতে পাইনি।
এইটা দেখা যাচ্ছে?
স্লাইড তো দেখা যাচ্ছে না। না না না।
ওকে, দাঁড়াও, ওকে, এক সেকেন্ড।
But another 5-10 minutes, how much time will take?
5 minutes.
Okay.
Almost done. Is it visible?
Now it's visible.
It's like hello. এইটা দেখাইল?
দাঁড়া, তুই তো এখন ফার্স্ট স্লাইড দেখাচ্ছিস, তুই এতে যা। Audible. You go to now this is the growth standard of the infants. এর আগে স্লাইড দেখা। Growth standards of
এটা দেখা গিয়েছিল?
না, এটা দেখা যায়নি। এটা নিউ দেখছি। এই যে এইটাও দেখা যায়নি, এটা দেখা যাচ্ছে। হ্যালো, জয়েন করতে পেরেছিস?
দেখা যাচ্ছে?
না এখনো দেখা যায়নি।
ভগবান, এটা দেখা গেছিল?
দাঁড়া, এইটা দেখাচ্ছিল। Yes, this slide you have shown. Go to the next slide.
দেখছি তো। এটা দেখা গেছিল?
না, এইটাই।
Okay, so this child did not have any features of growth failure, so we did not tested him for growth hormone deficiency, and obviously we did not prescribe growth hormone in this child. Now we have a growth standard for infants with Prader-Willi syndrome. However, this is available only till 3 years of age, so I don't know whether how far it's clinically relevant or not. So the US FDA approval was given in 2000, and it received the orphan drug status only in June 2020. However, in Europe, there is an additional indication of growth hormone in the form of disordered body composition. We do not know the optimal age of initiation, dosing, or durations. If you look at the different aspects, it has beneficial impact on each and every aspects of Prader-Willi syndrome. For an example, linear growth, body composition, fat-free mass, bone density, energy expenditure, and improvement of different metabolic parameters, measures of physical strength, cognitive functions, and motor skills. However, you need to discuss potential risk. If you initiate early, before 2 years of age, you are likely to get better outcomes. For an example, you are likely to get increased lean body mass, delayed fat accumulations, and enhanced skills. The median adult height in those treated with growth hormone is around -1 SDS, and almost 2/3 of Prader-Willi syndrome, they reach a height above -2 SDS. Now, what are the pre-treatment evaluations? You need to rule out hypothyroidism, both primary and central. More importantly, you need to rule out upper airway obstructions. You need to do a polysomnography to rule out central or hypoventilations. Diabetes, if present, should be controlled. And the contraindications of growth hormone therapy in Prader-Willi syndrome is severe obesity as defined by more than 225% of the ideal body weight, uncontrolled diabetes, severe sleep apnea, respiratory compromise, acute respiratory infections, active cancers, and psychosis. This child had an AHI-AH, or the apnea-hypopnea index, of around 6.6. So a suspected pathological breathing disorder was present in the sleep study. So you have to be cautious while giving growth hormone therapy in these individuals. Now you prescribe either an actual body weight based dose or a body surface area based dose. You start with a low dose. The starting dose should be 1/3 of the dose you use in growth hormone deficiency, in the form of 0.06 to 0.08 milligram per kg per week, and you gradually up titrate the dose to the standard replacement dose, which is 0.24 to 0.35 milligram per kg week. The greatest response is seen during the first 12 months. The improvement continues for 5 years. However, complete normalization is not seen. As I have said, you monitor IGF-1, you monitor for sleep apnea, hypothyroidism, hypoadrenalism, particularly if there are symptoms suggestive of hypoadrenalism. If there is new onset, snoring, headache, features of acromegaly, edema, high IGF-1, you decrease the growth hormone dose, and worsening scoliosis is not, sorry for the spelling mistake, worsening scoliosis is not an indication for discontinuation of growth hormone therapy, because scoliosis worsening perhaps is a natural history of the disease. The effect of growth hormone in adults have not been, the benefits have not been well established. You may get a modest benefit in body composition and cognition. However, growth hormone discontinuation after epiphyseal closure, as seen in adult growth hormone deficiency, you may get some advantages in the body composition and the metabolic parameters. Starting dose, like those in adult onset growth hormone disease, is 0.1 to 0.2 milligram per kg per day. You target the IGF-1 at the higher level of the age and sex specific reference range. And once again, you need to look at edema, and you all know that oral estrogen influence the dose. The safety issues, there are conflicting data on the effect of growth hormone therapy on central hypoxia or the sleep disorder breathing. There are studies which have shown that improvement in carbon dioxide responsiveness, resting ventilation, and airway occlusion pressure happens with growth hormone therapy in the past 6 to 9 months. And improvement in different inspiratory and expiratory muscle strength has also been established. The improvement of central hypoventilation is likely a direct effect of growth hormone on hypothalamic function. However, there are many case fatalities coinciding with growth hormone therapy. Those likely indicate precipitation of central adrenal insufficiency, and most of the deaths occurred within first 9 months of therapy, and majority of them occurred within first 3 months of therapy. The risk factors for sudden death are severe obesity, sleep apnea, respiratory tract infection, and aspiration pneumonia. The next is therapy for hypogonadism. For cryptorchidism, you may opt for a trial of beta HCG pre-surgery, and HCG for 6 weeks have resulted in stable total testes in almost quarter of those patients with bilateral cryptorchidism. The HCG therapy as a treatment for cryptorchidism is more effective than the idiopathic causes of cryptorchidism. They are also known to be associated with improvement in scrotal size. As I have said, primary hypogonadism is perhaps commoner than secondary hypogonadism, so you may need to opt for sex steroid rather than HCG for symptomatic hypogonadism. There is no Prader-Willi syndrome specific protocol for androgen or the estrogen therapy, but you need to consider the mood and behavioral changes after giving testosterone. Now, you need to manage the feeding and obesity problems both in neonates and infants, and also in children and adults, because they have significant reflux, poor suckling, so there is a high risk of aspiration pneumonia. However, you cannot rely on excessive calorie restriction in neonates and infants, which may have an adverse effect on abnormal in brain myelination and cognition. So you need to rely on different form of physical therapy, occupational therapy, and speech therapy. So calorie restriction in children and adults are the cornerstone. You have to provide vitamin, calcium supplementations along with low calorie diet. Behavioral modification is the main mode of therapy. They can be easily diverted from the food if behavioral signals for food intake are removed. So you need to impose a strict limitation of access to food using physical barriers, and they should be under close supervision. For behavioral symptoms, SSRIs, and for self-injurious behaviors, topiramate has been tried, but they are not very useful. Bariatric surgery is not recommended in these children because of limited data and more risks. There are certain issues that need to be considered while managing a patient of Prader-Willi syndrome, because they may react unusually with medications like sedatives and anesthetic agents. They are more prone to water intoxications, both with water and antidiuretic agents. They have high pain threshold that may mask infections or injury. They usually do not complain of vomiting. However, vomiting is an ominous sign in Prader-Willi syndrome and may suggest a gastric emergency or adrenal insufficiency. They also have body temperature abnormalities, giving rise to both hypothermia and hyperthermia. Easy bruising may lead to a diagnosis of physical abuse, and they also have thick saliva, increasing the prevalence of aspiration pneumonia. So this is an article published in JCM in 2020, an approach to adult with Prader-Willi syndrome. I have discussed all these issues, but if you look at the lowermost panel, central adrenal insufficiency has to be ruled out only if there is apathy, fasting, or symptoms suggestive of central adrenal insufficiency. So to conclude, Prader-Willi syndrome is the most common cause of syndromic form of obesity. However, it's still rarer compared to simple obesity, which we see day in and day out. There are typical clinical characteristics which may guide selection for genetic studies. Genetic testing is the gold standard. They are highly sensitive. If you look at the DNA methylation studies or the RNA expression studies or the methylation specific MLPA, they have an accuracy of around 99%. In our setup, methylation specific MLPA should be the ideal test to start with. To manage Prader-Willi syndrome successfully, you need to have a multidisciplinary approach. Growth hormone therapy needs to be given only if there is features of growth failure and there is no contraindication for growth hormone therapy. You need to consider certain aspects before giving growth hormones, and you also need to manage the associated endocrinopathies and comorbidities. Thank you very much.
Thank you, Partho, for your excellent and detailed presentation. We have covered almost every aspect of the Prader-Willi syndrome. So there are many issues of Prader-Willi syndrome. Now, if the audience have any question, please ask. Otherwise, we go to the next topic. So before
someone can't hear Pranab.
Hello, Pranab. Your
Yes.
microphone is muted, probably unmuted, or muted, probably.
No.
Okay.
Please.
Sir is telling. Sir can't hear you.
You are able to hear now?
I can hear you, sir.
Sir, can you hear me? Hello.
Okay, continue, Pranab.
So, I think what is your experience regarding growth hormone therapy in Prader-Willi syndrome? Your practical and clinical experience. What is the response? Have you given anyone
Yes, we have used growth hormone in Prader-Willi syndrome, but unfortunately, I don't have a very strong database on growth hormone therapy in Prader-Willi syndrome. I cannot remember the ultimate adult height they reached with growth hormone therapy, but we have used growth hormone therapy. But unfortunately, I don't have a significant follow-up data on those with Prader-Willi syndrome. I think Sarah or another may have comments on that.
Will you advocate growth hormone if the height is almost normal, or?
As I have shown you in one of the slides, that the patient I came across yesterday was not having any features of growth failure. So for as far as I am concerned, I am not interested in testing for growth hormone deficiency in absence of a growth failure. And if you look at the indications, the US FDA approved indication is growth failure in Prader-Willi. So if there is no growth failure, probably growth hormone therapies may not be that beneficial. But however, if you look at the European indications, they have shown that different dysmorphic features, the biochemical parameters may improve if you give growth hormone early in the course of the disease, particularly if in children less than 2 years of age. But however, I don't have any personal experience of giving growth hormone in children with Prader-Willi before 2 years of age.
Sir, may have opinion regarding anything regarding Prader-Willi syndrome or any?
No, that's fine. I think it was very well covered. Of course, there were those interruptions which we can't help. Now let's move ahead.
Okay, sir. Then I conclude this topic and over to Dr. Mahathi for the next topic.
Thank you. Thank you, Partha, for your excellent presentations. Now we'll move to the next topic, that is idiopathic short stature. And I shall invite our respected Professor Shubhankar Chaudhary, sir, who needs, I think, no introduction. So over to sir, please.
Thank you very much. Very good evening. I think the topics are very well chosen and not so often discussed in growth hormone symposium. Idiopathic short stature, of course, is mostly a diagnosis of exclusion. It still remains an area where the pharmaceutical industry wants everyone to be treated. In practice, many of us, I try and avoid treating, and there are pressures, especially from doctor couples, to treat their children who they think are not growing well enough with growth hormone. But we shall learn from Dr. Anirban Sinha, who is, of course, as we know, associated with Medical College Endocrinology Department, and is a very good speaker, and I'm sure he will give us some guidelines as to what we should follow. Of course, our prospects of treating many of these cases have grown significantly, especially in the medical colleges now that growth hormone is available for treatment. But we have to justify actually the cost that may be involved. So over
to group, that is the idiopathic short stature. If we categorize this, we can predict the outcome, and the ultimate target height, an adult height, can be predicted with more accuracy. Generally, the average adult height achieved in children with ISS are below the parental target height. That is mostly universal, but even as I said, the familial patterns are there sometimes, and that case it may be different. In case of suspicion of a specific genetic condition of short stature like Noonan or growth hormone insensitivity, the genes of interest should be examined. This is the current concept coming up. So then patients may not have the classic picture of Noonan syndrome, may have just a short stature, and the effect of IGF-1 is defective, and that end up in short stature only without any classical expression of Noonan syndrome. So any suspicion, we should go for a genetic testing with increasing availability of the genetic testing. So we can clearly define the cause of the idiopathic short stature which was classically previously considered as only idiopathic genes which are considerable for treatment. So is the prevailing issues in the family, prevailing issues in the culture, whether the girl child, whether it's a boy, whether they are more concerned about the height, but girls maybe sometimes more concerned about the height for the marriage. So these things should be also kept in mind for treatment consideration, because we'll discuss that treatment is sometimes not a great achievement, as sir has rightly said that we do not want to treat this patient because outcome is minimal, but even few centimeters, 3 to 4 centimeter gain may be beneficial for the parents' perspective. So it is a matter of discussion with the parents as well as the child, if the child is mature enough. But psychopathology is unlikely in this patient, but stress factors are definitely detected. So this is the classification of ISS. CGDP with normal height prediction, ISS with delayed bone age and tempo of puberty. C is ISS with normal bone age and tempo of puberty. D is ISS with familial component. E is ISS without familial component. So we just combining these two effects of CGDP and familial short stature in the categories of ISS, so that we can clearly define the treatment outcome and expected target height in the long run. This is the diagnostic workup of a short child as currently thought of. We'll definitely take the history of birth size, family history, mid-parental height, growth velocity, body proportions, dysmorphic features, presence bone age, and karyotypes in case of female, that is so obvious. And if there is abnormal body proportion, we can go for the skeletal evaluation and consider the diagnosis in that way. And if there is a signs and specific chromosomal abnormality, we'll go for genetic testing. And this spectrum is getting wider day by day, because even the stubble genetic changes can be detected by genetic testing and makes the picture clear for the diagnosis and treatment outcome. And abnormal birth size, small for gestational age, absence of the suggestive sign, whether there is signs of systemic and nutritional disease are present. If it is there, we investigate the patient. Absence of suggestive sign suggestive of endocrine disorder, we look for endocrine assessment. If it is not there, there is a gene patterns we should definitely look for even in the ISS groups, that is the SOX, HFR3, ACAN, and NPR2 and other candidate genes we'll be discussing shortly. And definitely the normal height velocity and normal bone age familial structure is considered, and normal height velocity with delayed bone age, we consider the CGDP patients as well. So this is the group of genes for associated with the endocrinological ossification, which are the candidate gene for idiopathic short stature. The first one came up in the diagnosis is that SOX, which was first reported in the patients of classic as ISS, is 1997, the first one. And this genetic defect has been documented. We know that SOX defect is many a way is chondrocyte defects, and there are many other diseases who are classically related with SOX defects, but sometimes stubble heterozygous mutation can only have the short stature without any defects otherwise. So the frequency of ISS in this SOX defect is around 2.6% of the ISS patient having the SOX defects. And additional common findings we should look for clinical cause is that mild abnormal body proportion and family members with Madelung deformity. If we can find it, there is a high chance of detecting and definitely screen for SOX defects. NPR2 and NPPC also is important for the cartilage proliferation, and these are detected in 2013 and 2018 respectively. And non-specific lateral abnormality and short metacarpals, I will show you the pictures how it looks like without any other classical presentation, just a short metacarpal with a short stature, maybe a presentation of these two mutations. And brachydactyly is also presentation of NPPC as well. Aggrecan protein, that is ACAN, is mutation first detected in 2014 in the ISS group, idiopathic short stature group, and frequency of ISS is 1.4% only, but still that can be detected with additional findings like accelerated bone maturation and early onset osteoarthritis in the patients. We can look for the ACAN mutation. Indian HF protein mutation is present in the ISS, first detected in 2018. frequency of ISS is around 3.4%, is not so bad. It's almost more than the SOX mutation as well. And shortening of the middle phalanx of the fifth finger is maybe the only presentation of IHH mutation. And that way, these stubble changes, if we look for, we can classify even the idiopathic short stretcher with the specific genetic defects and screen for them. And FGFR3 is a very known factor for condrocyte, is an inhibitor, and mutation is effective for short stretcher, and that classified in the group of idiopathic short stretcher in 2015. Frequency is still not available in the pictures. There are very isolated reports. Only one family describes with normal body proportion, even with RGFR3, which is not classically expected. For example, this is a picture of children carrying NPR2 and IHH mutation. First one, it is hand radiograph of patients of NPR2. We can see the shortening of the metacarpals. If we compare with the normal hand, it's very more clear. And second picture, just look at the heterozygous mutation of IHH in the shortening of the middle phalanx of the fifth finger. If you can see here, the fifth finger as a shortened middle phalanx, and that is otherwise very stable unless we look for, and that maybe give a clue of diagnosis of mutation of IHH as well. So this is the way we can differentiate even the group of idiopathic short stretcher with different subcategories. And coming to the second group, that is the defect in the growth hormone IGF-1 axis with isolated short stretcher. So growth hormone mutation, as I said, may not be classical. So it is first detected in idiopathic short stretcher in 2003. Frequency is still not available, and inheritance is autosomal dominant. They present with a low height velocity and delayed bone age, more of a classical growth hormone deficiencies. But growth hormone, this ghrelin receptor, GHSR secretagogue receptor, this is a ghrelin receptor which is first reported in the ISS in 2006. Frequency is around 2 to 2.4%. Both has autosomal dominant and recessive presentation, inheritance. As the same family, growth hormone deficiency and ISS has been spectrum disorder in some families. So this way it can be considered that way. So GHR receptor mutation is detected way back in 1995. Prevalence is around 5%, up to 5%, autosomal dominant mutation, inheritance, and laboratory suggestive of partial growth hormone insensitivity is a stable changes like marginally high IGF-1 levels, maybe low IGF-1 level and high to normal growth hormone levels are slightly detected in this population. STAT5B, again a downstream pathway of growth hormone activation, growth hormone receptor activities, and this is detected in the idiopathic short stretcher in 2018. It is again an autosomal dominant inheritance, and three family had eczema with suggestive of growth hormone insensitivity have been detected with the gene defect of STAT5B. I understand these are very rare mutations, but some of them are very high frequency as compared to the idiopathic short stretcher group. So up to 5%, as I've said, GHR receptor mutation. So it is where we look at it, and if you can detect these defects, and this can be more predictive of final height gain and treatment procedures. For example, IGF-1 mutation detected in idiopathic short stretcher in 2012, again is autosomal dominant inheritance. Birth weight and birth leg is lower than normal range in this population. And IGF-1 receptor mutation detected in 2003, around 1.6 to 2% of the ISS population having this mutation is the autosomal dominant inheritance. They are born for small for gestational age in most cases at slightly elevated IGF-1 levels. And the receptor complex IGF-ALS and the triplet, this defect again is there, detected in 2004, the protein complex, and this is also autosomal recessive inheritance and severe deficiency of IGF-1, IGF-PP3 disproportional to the short stature. If we can screen this patient, we can find this. So is the PAPPA2. This is again a triple complex part of it, and this is also as autosomal recessive mutation, and high levels of IGF-1, IGF-PP3 is a characteristic finding in this mutation. So though these are classically a ISS by diagnosis, but genetic testing classifies them at least If we combine these, around 10 to 20%, almost some studies says 30% of the population can be, of the ISS population can be detected with classical genetic defects. Definitely less 70% still not detected, but if we get more and more genes and more genes are coming up, actually every year maybe 1 or 2 genes are detected in this list, added to the list. So ultimately we may get the definite cause of all the idiopathic short stature. So this is another way of looking at the defects, that is chromosomal CNVs. By using the hybridization of the patient's DNA and reference DNA, chromosomal microarray detects the genomic imbalance such as submicroscopic deletion and duplication, as we are discussing before. So here also CNV can detect the microsomal deletion and duplication. These imbalance are known as CMVs and include the other heritable and novel variations number of the gene copies. So these are evolving changes. So not all the CNVs are known. So this just imbalance of deletion and duplication. So this is not classical way of detecting in the classical genetic testing. CNV seems to be responsible approximately 10% of ISS cases as per the different studies. Knowledge of stemming from the identification of CNVs in the children with ISS can help to identify the novel gene involved in the growth regulation and the pathophysiology of the ISS. So more and more genes are coming up in the pathophysiology of growth regulation, and if these defects are detected, we can definitely find out the pathway blockage and treat accordingly. The best way to, at present, to detect the genetic defects in the idiopathic short stature is the next generation sequencing. This approach has been led to the detection of pathological variants of children with ISS. Genome-wide association scan has the advantage of analyzing the coding DNA and therefore considered in the most limited amount of data. And WES has a diagnostic yield of around 36%, but NGS, that is next generation sequencing, has recently been proposed as the primary diagnostic tool for children with ISS. For example, a Chinese children study of ISS, genetic cause was detected in 36% of the patient, which is pretty impressive. And most cases were detected by NGS, that is 33%. So NGS is very effective in detecting out the genetic defects in the ISS patients. NGS was applied to the cohort of 33 children with severe familial short stature with growth hormone for SGA and GSD indications, led to the identification of genetic cause of half of the patients. So we classically take it as severe familial short stature, but genetic defects are documented if you go apply this next generation sequencing. But there are hypotheses that epigenetic changes are also there in the regulation of growth. So it is under process to look for that epigenetic sequencing and imprinting disorders, as we have discussed before, and these are also increasingly applied in the detection of idiopathic short stature. Coming to the issues of treatment of short stature, children with ISS have a broad range of provocative growth hormone response, ranging from the normal to elevated, and the wide range of serum IGF-1 concentration from normal to IGF deficient. So this is a heterogeneous group, so response is also heterogeneous. There may be experienced stressful behavior. The study suggests that relationship of the psychological problems to the short stature is variable and not statistically significant. Nonetheless, the hormone intervention to enhance growth is diminished, such as difficulties has been used. Some of the specific etiologies are often unknown. Growth hormone treatment has been used widely, so that is more of a blinded approach to get some height either way. So unless we get a specific etiology, as we have discussed before, we can specifically detect which patients are going to respond to the growth hormone therapy and which patients are not. And that way we can treat the patient wisely. There are concerns about financial, ethical, and psychological aspect, as we have discussed before, that not all the patients can afford it, though it is given free of cost in government hospitals, but how long it will be provided, no one knows. And still we have a issues constraint, so not every patient should be given growth hormone without judgment. So ethical, financial, and psychological impact of the growth hormone therapy should be considered in the normal short children, because some children are short and they are happy with it, so there is no issue of giving a growth hormone therapy, which they are not concerned of. 5% of the population will always be the below 5th percentile, as we all know. This is the normal physiology, and focusing on the short stature could potentially handicap the otherwise normal child psychologically and society. So we can encourage the child or the young adults to get a more healthy psychologically rather than obsessed with the height. At least I try to do it myself when I see a short stature patient. Also, there is no convincing data to support the growth hormone treatment of short children definitely improves the psychological, social, and educational function, as Professor Chaudhary was rightly pointed out. So we do not want to treat this patient because there is no definite benefit either way, both as a height or as a psychological, social, or educational function as well. The final adult height of the subset of the children may be adequate even without any treatment. So one component is observation, and definitely that works sometimes. And also known and unknown treatment risk of growth hormone therapy, as we have discussed with the previous speaker, with the growth hormone risk remains same for most of the treatment at different etiologies as well. When there are studies, I remember saying that French cohort study had a significant increased risk of neurovascular events. So CVAs are increased, and there are also increased risk of bone cancer, but definitely other cohorts from the European countries did not show any increased risk of malignancy in any of the areas. So there is a discrepancy in the data outcome. These are the all registry data. More than 6,000, 7,000 patients were being studied in all the groups, as I was saying. So response are heterogeneous. So there are maybe a risk if not confirmed. So we should not treat the patient blindedly, and we should follow them up with the side effects as well as risk concerns. At the same time, many children who do not meet the criteria for diagnosis of growth hormone deficiency have similar degree of growth retardation in the children with established GHD, and these patients may be suitable candidate for growth promoting therapy. So it is depending on the clinical decision making as well. As I said, all the genes are not detected. Even the genes may not detect the classical defect of growth hormone deficiency, but there are some similarity maybe we find in the clinical studies. So in this patient, we can still consider the growth promotion therapy. So the members of the Growth Hormone Research Society, different Pediatric Endocrinology Society, European Society of Pediatric Endocrinology, 2007, the primary goal of therapy should be attainment of the normal adult height, and if the response is not adequately resulted, we should withdraw the therapy otherwise. So growth hormone, there are different doses has been tried. Grossly, the higher dose is beneficial in the idiopathic short stature compared to the growth hormone deficiency. At 0.22 milligram per kg given thrice weekly in the subjects with a mean starting height at around -3 SD has shown some benefit. European idiopathic short stature group, they have shown growth hormone doses around 0.2 to 0.37 milligram per kg per week, the higher doses. At around 6 doses per week in the children with a mean starting dose around -3 to -3.4 SDS. Improvement of the higher dose group exceeded that of the lower dose group by around 3.6 centimeters. So that definitely gives you an edge. So it is recommended to start with the higher dose around 0.37 milligram per kg per week in the idiopathic short stature if you consider to treat. When the data from the two trials are combined, the cumulative gain was 7.3 centimeter in the group treated with the 0.37 milligram per kg per week compared to the placebo. That is quite impressive. But point is, these height gain are sometimes not always with the ultimate adult height gain in the studies. Their predicted adult height gain is actually considered in the studies, so that is not equivalent to the classical ultimate adult height. So adult height sometimes are not known, so these benefits are impressive, but they are actually predicted height gains. In the meta-analysis, around 1,000 children, 4 control trials, mean height gain of around 5 to 6 centimeters has been seen. That is a more, maybe a generous statement. Maybe we expect a child to gain around 5 to 6 centimeters at the most with the growth hormone therapy in the ISS. That can be explained to the patient and the parents. FDA in 2003 has approved the growth hormone treatment in the ISS patients. Some suggest treatment if the height is more than 2 SD below their target height, or if the predicted height is below -2 SD, or both. So these are not confirmed, but there are some suggestion. There are no consensus or age of initiation of treatment, but more of them says that children from 5 years to early puberty respond better. Bone age is used to predict the adult height. Bone age delay has an effect on the precision of prediction as found in the longitudinal studies in different ISS patients. Bone age delay about 2 years, average adult height almost equal to the predicted height. Bone age delay is not there, then adult height is greater than the initial predicted height. bone age delay is more than 2 years, the adult height is significantly below the predicted adult height. So we can just get a bone age delay and we can predict the ultimate adult height patient can expect with the growth hormone therapy. And that is quite important to discuss with the parents. So this is again with the different responses with the growth hormone therapy. And we can see that observation is the lowest one. Then oxalinolone, that is one way of treating the patient without growth hormone. That also gives certain benefit, but ultimate adult height is same. Then human growth hormone therapy until the onset of puberty or normal range height. So that shows certain benefit definitely beyond the oxalinolone. And growth hormone therapy until the growth is complete, that is much better and get a age over the until puberty groups. And the increasing dose at the puberty and ultimate the final adult height is the maximum height gain detected in the child of adult height gain with the short stature child with idiopathic short stature. Most short stature children treated with growth hormone experienced growth acceleration has usually sustained over the first several years of therapy with attenuation of the treatment response over time. So we need to follow them up yearly at least to get the height changes. If the patient has stopped gaining height, we can consider withdrawal. So our pre-treatment growth velocity and higher weight to height ratio, that factors suggestive of GHD, and a lesser degree and bone age retardation are associated with the better early growth responses. So this factor should be kept in mind when we decide the treatment. Growth hormone of 0.2 to 0.25 milligram per kg per week in GSS has resulted in the mean gain of around 0.6 to 0.9 SDS. These children continues to be short as adult, but there are definitely some gain, but they are not as normal as the adults are supposed to be. In children who did not have familiar short stature and the mean final height was found to be greater than males than females, with average gain of around 1.2 to 0.9 SDS respectively. So these patients who are not familiar short stature get a reasonable good height and which are greater in the males. Response to growth hormone therapy in children with ISS is highly variable and definitely dose dependent. As I said, the population is heterogeneous, so response is also heterogeneous. So for example, defect in the cartilage, genetic defects, so they may not respond well with the growth hormone therapy. Otherwise, the defect in the growth hormone IGF-1 axis, some axis defects respond very well to the growth hormone therapy. Mean increase in the adult height with the ISS around 3.5 to 7.5 centimeter. That should be discussed with the parents. Best response is seen in the children who are younger or heavier, those receiving the higher growth hormone dose, those who are shortest relative to the target height. An adult height outcome is positively influenced by mid-parental height, initial height at treatment initiation, delayed bone age, as we have discussed before, 2 years, more than 2 years, or less than 2 years. Magnitude of the first year response to growth hormone therapy is very important to consider the response of the growth hormone in the ultimate adult height. And adult height is negatively influenced by the age of initiation of therapy. So if you start very late, the response is minimal. That should be clearly explained to the patient. Monitoring, sorry for the spelling mistake, the same as a growth hormone with the other indication we have discussed before. Height, weight, and the pubertal development and adverse effects should be looked for. Those should be monitored 2 to 3 times per year. We have discussed about the complications like scoliosis, tonsillar hypertrophy, papilledema, and slip capital femoral epiphysis. Even the simple joint pain, arthralgia, or swelling should be looked for as well. Routine monitoring of glucose metabolism is routinely not advised, but if the family history of diabetes in the pubertal ranges, we can sometimes look for it. IGF-1 may be helpful in the guiding the growth hormone dose adjustment and should be kept within the first upper QSD of the age-specific ranges. So this is the estimated average adult height with the different therapy responses, just to give a picture of how it works and how it may not work. So no medication.
Anirban, can you wind up in the next few minutes?
Yeah, I will do that, sir.
We're being unfair to you because we started a little bit late, got late with the first talk. Yeah, please go ahead.
Yeah, I will do that, sir. I definitely will do that, sir. Just to say that different responses. So no medication versus oxalinolone was almost similar. Growth hormone therapy gives slightly age over. Growth hormone with a lower dose versus higher dose have a maximum attainable height if we give a higher dose and longer duration. So I'm just repeating that there is no data the long-term growth hormone safety with more than 0.5 milligram per kg per week. So we cannot give very high dose of growth hormone therapy. IGF level should be helpful for assessing the compliance and growth hormone sensitivity and responses. IGF levels are elevated should prompt consideration of growth hormone reduction, and stopping of the treatment is recommended if the adult height is achieved, like height velocity less than 2 centimeter per year and bone age more than 16 in the boys and 14 in the girls, as with any other standard recommendation for treatment. The cost is huge and there is nothing to say. Benefit is less clear because it is unknown whether to gain height improves the quality of life, as Sarah has rightly mentioned in the beginning. So it is a chance factor sometimes because the defects are unknown, which defect is causing the idiopathic short stretches. So some defects respond to the growth hormone therapy, some defects don't. There are GnRH agonists are tried with the growth hormone therapy. They have been shown have the short-term adverse effects on BMD, so they should be given wisely. And if at all used, BMD should be screened. Combination therapy, GnRH agonist and growth hormone has a potential value of increasing final height, but minimal data is available up to 3 years only. So it is still not clearly indicated, but can be tried. So just this is a tabular response of therapy in the different defects with the different therapies, not the defects. Sorry. So recombinant growth hormone versus GnRH analogs versus combination of these two, we can see that mean height gain around 10 centimeter compared to the height gain of isolated, which is much less of either of these two. And aromatase inhibitors can also be used in the idiopathic short stretcher studies, and they shows around increase around 5.9 centimeter in the patients. Aromatase inhibitor with growth hormone therapy again tried in randomized TM studies, and near height gain with around 22.5 centimeter gains in the growth hormone plus aromatase inhibitor therapy. So that is also impressive, but very limited data are available. Definitely, you can see that 76 patient ISS boys are already treated. Recombinant growth hormone plus IGF-1. This is a very impressive look, but definitely did not studied much. So only 106 subjects were treated with short stretcher in this group, and open label study shows gain of around 11.2 centimeter per year in the group treated with 45 microgram per kg of recombinant growth hormone and 150 microgram per kg of IGF-1, recombinant IGF-1. So gain is very impressive, around 11.2 centimeter per year, but duration is 3 years. Similar safety profile between the groups has been documented. If possible, these are the best one, but study effects are limited, so it is not recommended till now. So this is the last slide, maybe discussing that decision regarding the treatment of short stretcher is not related to the growth hormone deficiency, complicated with the uncertainties of adverse consequences. So risk benefit ratio should be looked for, and therapeutic goal should be clearly discussed with the patient. If treatment is initiated, should the goal be acceleration of short-term growth or adult height? That is a debatable issue, and parents are more interested in the immediate short-term gains. Last 1 to 3% potential height gain may increase in the total expenditure of 20%. So 1% gain of height can increase the expenditure of 20%. Whether it is a cost-effective or not, that is a debatable issue. ISS is still a challenge. A controversial diagnosis or definition which should be revised and include the stricter criteria ruling out the subject with CGDP and familial short stretchers. As I said, the genetic testing is coming in a big way in the ISS patients. Molecular characterization of high proportion of ISS patients lead to the stratification of the ISS population, as I have tried to discuss. And we can go for a tailored management in these groups. So multiple gene testing approach in the NGS, that is next generation sequencing, is preferable. For example, it is known that patients with SOX defect have a good response to recombinant growth hormone therapy, but less severe GHR receptor mutation will respond less to the recombinant growth hormone therapy and regular doses. So we can definitely understand if we can detect the genetic defects, we can definitely predict which patient are going to respond to the growth hormone therapy, and will not waste our expensive growth hormone therapy in the randomly in the ISS, all the ISS patients. Thank you. And this is to mention that short man syndrome should not be expected in the short child. So it is feeling of inadequacy in the lack of height that should be explained to the child and discussed, so the motivated the child is important. Rather discuss the patient, what are the benefit of having a short stretcher, and make the feeling that it should be a positive way of looking at the life, even the patient, child or patient is short. Thank you very much.
Thank you, Anirban.
Over to you.
It was quite comprehensive. We do understand now that idiopathic short stature, of course, is quite a heterogeneous entity. In my dictionary, I think familial short stature should not be included when we diagnose idiopathic short stature. CDGP should ideally be excluded, but I think in a pre-pubertal age, at age 5 or 6 or 7, there isn't a way of catching on CDGP very confidently. So there will be admixture of some of those patients. And in terms of treatment, I think if growth hormone were, the cost of growth hormone had come down significantly. And I feel that with recombinant DNA technology, there is the potential to get the cost down, but somehow the pharma industry maybe have struck maybe contract amongst themselves and decided agreement amongst themselves and decided they won't bring down the cost, but potentially the cost could be much lower. If had become lower, then I think there is a potential to use in many cases, because and I'm a little bit surprised that generally the studies have suggested that they do not show increased incidence adverse effects versus growth hormone therapy in other conditions. So that is a little bit surprising to me, that you need not monitor glucose and all. Of course, at such young age, you do not expect dysglycemia a significant extent. So if the cost had become less, possibly there will be scope to use growth hormone more often. But at the same time, as Anirban has also correctly pointed out, there may be certain subclasses of so-called idiopathic short stature which would respond better, and we may have better tests to identify them maybe in the next 5 or 10 years, and then use the hormone more effectively. So are there any questions or comments? There aren't any questions in the chat box that I can see, but this chat box, who will fill up this chat box? This is only amongst the faculty, the chat box that I'm seeing. Anyone in the faculty wants to ask a question? Am I
No,
audible?
sir. Yes, sir.
Yeah.
Audible, sir. This chat box is filled up by from the audiences. They send these questions to us. And,
okay. So Anirban can unshare now, and we can go on to the next topic. Or the next is the panel discussion, isn't it?
Yes, sir. So, sir, if anyone can take these questions and can answer, so that
where are the questions? I didn't see any.
Yeah. I'm here.
So then I am telling the questions.
Yeah.
Oh, okay. So, I can't see.
So
yes.
Okay, sir. So one question from Guwahati, from Dr. Avamoni Baro. So her question is growth hormone therapy for achondroplasia, whether we recommend or not. Anyone?
Yes, growth hormone therapy for achondroplasia is conventionally not recommended, as my understanding goes. So it is not of much benefit. But there are few studies we have tried, as I understand. I read before. Sir, over to you if you have anything to say.
No, I wouldn't suggest at this point. No.
The second question is from Andhra, from Shruti. When to do induction of puberty in isolated growth hormone deficiency and in multiple pituitary hormone deficiency?
Though this is not the
topic today
now. But would you like to comment?
Sir, if you have,
so let's try just to try that. I will prefer to be delay the pubertal onset a bit later, as I discussed in my slide as well, because there are studies with oxandrolone with response to growth hormone therapy, and GnRH analogs have been tried along with the growth hormone therapy to get a better height. So if there is a chance of delaying the initiation, no, not outside the range of the expected pubertal days. So if it's slightly, from example, from 10 to 12, if we can delay the 2 years of puberty, then we can get a more height compared to the puberty started around the 10 years of age. So within the range, we can delay the puberty maybe. So what to say?
Yes, that is usually what we try and do. And at the same time, we do remember that with puberty, generally the growth hormone doses are also increased in the process of puberty as well. Yeah, so we can't delay it too long, and neither does it actually lead to significant height advantages, but maybe 1 or 2 years delay, yes, definitely we do use, and I think is of some benefit, especially in our setting where many of the patients come relatively late and almost in peripubertal age. So we do that, right?
Okay.
So thank you very much. Thank you, Anirban.
Yeah. Thank you, sir. Thank you, sir. And thank you, Anirban. So next we will move to our next session, that is the panel discussions. And in the panel discussion, the topic is the growth promotion in Turner syndrome. I being the moderator, and there are panelists and the renowned endocrinologists, the Dr. Partha Sarathi Chaudhuri, who is a senior resident attached in the Department of Endocrinology, Medical College, Kolkata. Then Dr. Subishwar, who is a clinical tutor attached with the Department of Endocrinology, Medical College, Kolkata. Then Dr. Arjun Boiddo, who is associate professor attached with the Department of Endocrinology, NRS Medical College. Dr. Soumik Goswami, who is a clinical tutor and attached in the NRS Medical College in Endocrinology Department. Then we have with us Dr. Rana Bhattacharya, who is assistant professor attached with the Department of Endocrinology, SSKM and IPGMR Hospital. So without delay, I would like to start this discussion that the Turner syndrome, as you all know, is one of the important endocrine disease normally we come across in our hospitals, I mean the OPDs as well as in the mainly in the hospital OPDs. And the three important concern is the short stature, primary infertility and amenorrhea. So short stature is one of the important concern. And when I am this DM trainee almost 10 years back, at that sorry, at that time the use of growth hormone in Turner was not that big. Maybe we have I have seen maybe 1 or 2 cases. The reason maybe the cost is one of the important factor, as sir has said, that the cost of the growth hormone, though it's come, it have come down little bit, but it's not in that big way so that it can be used, bearing the other situations of growth hormone deficiency where it would be most cost effective. And also there are not much studies at that time to back up the use of this growth hormone in Turner syndrome. But nowadays the scenario has changed and many studies has come. So, but there are definitely conflicting evidence and there are side effects, issues. So let us start with the discussion. I will put a question. I mean, I should ask Dr. Parthupatim Chaudhuri. Before that, I will ask whether everybody is there in the board. Dr. Parthupatim, are you there?
Yes, sir. I am there, sir.
Yeah.
Am I audible, sir?
Yes, yes. Dr. Subir, are you there?
Yes, yes.
Yeah. Dr. Arjun Boiddo?
Yes, you can see me.
Okay, okay. Dr. Soumik, are you there?
I'm there. I'm there.
Yeah. Dr. Rana, are you there?
Yes, I'm
yeah,
there.
Okay.
I'm here.
So start with Dr. Parthupatim Chaudhuri. So what are the causes of short stature that we come across in Turner syndrome? Let us discuss that first. Partha, please.
Yes, sir. Sir, am I audible, sir?
Yes, yes.
First of all, a very good evening to all my respected teachers and colleagues. Sir, actually, the causes of short stature in Turner syndrome, I mean, short stature is actually the most common physical abnormality in Turner syndrome. And usually it is found that almost all patients with Turner syndrome usually have short stature. Now, the causes of short stature in Turner syndrome is mainly due to the SOX haploinsufficiency, which is a genetic cause. And besides, this is the most common cause of short stature in Turner syndrome. And other common causes that may arise in Turner syndrome is due to associated autoimmune hypothyroidism due to Hashimoto thyroiditis, or due to associated celiac disease, which is usually may be found in Turner syndrome patients. So these are the usual causes of short stature in Turner syndrome. Sir, am I audible, sir?
Yes, you are audible. As rightly Partha has said rightly that these are the most important causes that we come across in the as a cause of short stature in the Turner syndrome. Also, there are some genes that may be responsible which are present in the X chromosome and that do not undergo inactivations. So these are the primary causes. Then I will move to Dr. Soumik Goswami. So what are the evidence that suggests that growth hormone therapy in Turner syndrome may be beneficial? Can you enlighten us?
Animesh, can I comment on the
Soumik? Yeah.
Animesh, can I comment on the first question?
Yeah, you can comment.
Other than the factors which already given by Dr. Parthasarathi Chaudhary, the other important factor I think is the delayed puberty and the lack of growth spurt because of pubertal initiation in Turner syndrome. This is most important, I think, other than shock supply insufficiency. And also, obviously, we should consider growth hormone insensitivity. Some amount of growth hormone insensitivity is also there. And we should also keep in mind that celiac disease might be associated with Turner syndrome.
That Partha has mentioned celiac disease, as you have said, delayed puberty is a part of this Turner syndrome. Yeah. Hello. If you initiate at the right time with estrogen therapy, that in one hand that can lead to early bone maturation and may not you get that adequate height, though nowadays the studies have come with a low dose estrogen that we'll discuss next. So okay, that's a good thing. So now we will, as I have moved to the Dr. Soumik Goswami. Soumik Goswami, please, can you hear me, Soumik?
So I won't name individual studies, but there are some big studies. One is the Turner toddler study, which began growth hormone from 9 months of age. There is a big Canadian registry, French registry. There are several other studies as well, but the overall evidence is that if you administer growth hormone at the proper dose, particularly with an optimal timing at the proper time, you gain height on an average of about 5 centimeters. The range is big. It's 4 to 16, as low as 4 to as high as 16, but on an average, it's about 5 to 6 centimeters gain as from the published evidence. That is what we know.
Okay. So it's as Soumik has rightly said that nowadays there are many papers are coming. So we can gain the height, adequate height in Turner if we give growth hormone therapy. Now we'll move to Dr. Rana Bhattacharya. Can you enlighten us about how to initiate the growth hormone therapy, how to monitor properly?
Yes. Thank you. Regarding the initiation, two important considerations are there. One is timing and the other one is dose. Regarding timing, there is clear evidence that as early you can start is better, means that usual growth faltering occurs around 2 to 5 years of age. So if the height falls to less than 5th centile, as soon as possible, one should start therapy. But we rarely come across patients who presented at such a younger age. But we actually are fortunate to have few of Turner syndrome who presented at that age because of some congenital neonatal features like perinatal edema and some startling stigmata for which the patient was referred to us. So that is very important. So usually if we start by 2 to 4 years or 2 to 5 years, maybe the response is very good. If you start late, as Shomik has pointed out, there is a wide range, and one of the most important factor why there is such a wide variation of range is the starting time of the therapy. So earlier start, better the response. Now, when the patients presents peripubertally, usually if the bone age is around 13 to 14, we usually avoid giving growth hormone. The 14 years of bone age, possibly there is no help. Even if the patient is already on growth hormone, we stop once the bone age of 14 is reached. And to begin with, we do not start when it is 13. Now, regarding the dose, usually we start with a fixed dose. The standard dose is 0.35 milligram per kg per week. So that's the minimum standard dose required for this condition because there is some element of resistance. And there are some data which suggest that if you start early at this dose and you can escalate it up to the evidence is around 0.65 nanogram per kg per day, which actually converts to around 0.46 or 0.45 milligram per kg per week. So if you escalate to that dose peripubertally, there is additional height gain of around 2 to 3 centimeter, which is quite significant. So that is another important thing. Thirdly, regarding dose escalation, regarding the other standard monitoring, like the monitoring for adverse effects, like acute adverse effect, like headache, sleep femoral capital efficiency, and so on, or the long-term adverse effect, which are relatively rare, like possible exaggeration of scoliosis and so those we should monitor. But regarding the biochemical monitoring, we should look at the IGF-1 level itself. The reasoning that we should target IGF-1 between 1 to +2 standard deviation. If it is beyond +2 standard deviation, there is more chance of side effect. Now, regarding height monitoring, as you have asked regarding monitoring, it's very important to monitor the child on a Turner specific growth curve. Now, I think all of you have used that particular chart. That chart has an advantage that it has two kind of graphs. One set of graph actually is for the Turner children, and the other, the same paper contains the graph for non-Turner girls. So there is advantage that with the same chart, you can monitor the child. Firstly, you can monitor to see whether there is faltering of growth according on the Turner specific curve, as well as when you give treatment, you can target the patient to the according to the normal, because your target is to achieve the so-called normal adult height, at least to the lower percentile ranges. So the chart has both of this component. So you can monitor accordingly. So these are the ways to monitor. So I think,
okay.
Yeah.
Okay, thank you, Rana, for your, nice, deliberations. How very nicely you have said how to start at what doses. Maybe sometimes we, though FDA has recommended 0.375, normally we give, as you have said, 0.35. Then we build up the dose. Then I will move to Dr. Arjun Vaidya. Kindly illuminate us about how to optimize the growth of the Turner patient. What are the factors basically that can improve the final height by giving the growth hormone?
Some of the points already elaborated by Dr. Bhattacharya, that according to the IGF level and clinical monitoring, we can increase the growth hormone dose with time. And some of the important parameters which can predict the which can predict the final adult height with growth hormone therapy is the response in the initial years, that is initial first year or first 2 years, and the early initiation of growth hormone therapy and the bone age delay. And these are some of the factors. And I think some of the also chromosomal defect, some of the chromosomal defects can also might have better response, and some might have poor response. And also we can optimize the final height gain with induction of puberty with low dose of estradiol in adequate time with low dose of estradiol during the peripubertal period, when the bone age is in the pubertal range, that is 9 to 11 years of bone age. We can initiate the low dose estradiol therapy. And regarding the low dose estradiol therapy, I think the patch formulation has the advantage over the oral formulation, and it provides the better IGF-1 response. As we all know that it bypasses the hepatic phosphorus metabolism. So this is regarding the optimization of the growth hormone therapy. And in some of the studies, it was seen that oxandrolone can also be added. This is a non-aromatizable androgen. So that can also provide additional height gain of about 3 to 5 centimeter in addition to growth hormone therapy height gain.
Okay, so Arjunda has very nicely said about the what are the factors. Maybe I mean the higher dose, if you use higher dose, that may lead to additional height gain. Okay, so let's move on to Dr. Subis sir. So what are the factors that predict the adult height or final height of the Turner patients? Even if you give growth hormone, you may not get those targeted height. So what are the factors that actually predict? Already Arjunda had said something, I mean many factors. Then what are the other factors?
Actually, many factors are already discussed. First, the initiation, time of initiation is important. Actually, if we detect the Turner syndrome at very early age and monitor in the growth chart, and if there is, we detect faltering of growth. So as Dr. Rana Bhattacharya already said, if the below 5th percentile, so we have to start the growth hormone therapy. The time of initiation is important. So as early we could start, that will give a better result. And if associated other disease we can detect, like hypothyroidism and celiac disease, the treatment of this associated condition also improve. And also the Turner syndrome requires the optimal dose requirement of growth hormone is quite higher than the other population. So that in proper dose it should be used. And we can also if we get the patient at a later stage and just before puberty, so before induction of puberty, we can, if we delay 1 or 2 years, that will give additional height gain we can achieve with that. And already Dr. Boiddo said that transdermal estradiol preparation for induction of puberty will give better result. And some study shows that use of oxandrolone along with growth hormone gives better result.
Okay, so Subir and Dr. Boiddo has almost covered every aspects. I mean, what are the factors? However, the initial height of the patient, or maybe parenteral heights, if it is target height is more than the outcome, maybe more, or if the population height is more, that maybe outcome may be more in that cases. Then I'll move to Dr. Partho. Can you enlighten us when to grow, whether we normally routinely do growth hormone testing, I mean for the diagnosis for before giving growth hormone in Turner, or if it is not, then when we normally recommend growth hormone testing in Turner?
Actually, in Turner syndrome, the growth hormone dynamic tests are of not much use because it has been seen in many studies that the children with Turner syndrome usually have normal response in growth hormone dynamic test. So, as Rana sir has already told that by measuring the growth over the growth chart, by plotting over growth chart, when growth usually goes below the 2 percentile or it falters in the growth chart, then usually the growth hormone treatment is to be initiated. There is not much benefit in growth hormone dynamic test in the diagnosis of Turner syndrome.
You're not audible, Dr. Maiti.
So when to test for the growth hormone deficiency or other causes of, the short stature, when you are monitoring in the Turner specific growth chart. So normally we do not do for this growth hormone testing, but when to do that?
Sir, in Turner syndrome, when should I? Sir, may I?
Yeah. You can answer.
Am I audible, sir?
Yes. So if somebody you are monitoring in Turner growth specific chart, but if she slips down even from the the Turner specific growth chart, it's coming down. So probably you need to then reevaluate whether you are dealing with a growth hormone deficiency or say other causes of short stature like celiac disease or like that. So otherwise you need not to do any test before embarking on growth hormone therapy. Then hello.
If the patient is on growth hormone therapy, I think even if there is growth hormone deficiency in Turner syndrome, the patient should respond if the dose is adequate. Once the patient is on growth hormone therapy in a Turner patient, even if the patient has growth hormone deficiency.
No, I am not telling on growth hormone therapy. The patient is, you are monitoring Turner specific growth chart when to do the test before embarking on growth hormone therapy.
I am coming to the point. So I think before initiation of therapy, we should do IGF-1 for further monitoring with the IGF-1 level. If the initial IGF-1 comes low, then we should think of growth hormone deficiency, associated growth hormone deficiency in a Turner patient. I think that should be the. Once the patient put on growth hormone 3 without doing dynamic test of growth hormone insufficiency, even if the patient has growth hormone deficiency, that patient should respond if the dose is adequate.
No, usually not. Normally, we do not come across the growth hormone deficiency in Turner. So
you need not to. There are few case reports of growth hormone deficiency.
Yeah, but for that you need not to do IGF-1 for every patient of Turner before giving growth. Rather you should follow the growth in the Turner specific growth chart. If you find that it's slipping down, then
recommendation is we should do IGF-1 level at the baseline for the further monitoring. Compared to IGF-2 level.
Where? Anybody in the panelists can.
Therapy, we should monitor with the IGF-1 level as well, along with the clinical parameters. So
that you have said rightly. When a patient is on growth hormone during monitoring, as Dr. Anna Bhattacharya has said, that you need to monitor IGF-1 and that should be maintained between
value. For that, you need a baseline value of IGF-1 level. If that baseline value comes low, then we should think of growth hormone deficiency in Turner syndrome. That is the point.
But actually, if there is growth faltering on Turner specific chart, then only we suspect growth hormone deficiency or other associated disease like celiac or hyperthyroidism.
What I am trying to stress is that even if the patient has growth hormone deficiency and the patient has Turner syndrome, if the patient is on adequate growth hormone therapy according to the recommended dose for Turner syndrome, that patient should respond to the growth hormone therapy. That patient should not be a falter, should not falter on the growth curve.
Okay.
That's the point.
So okay. It's the point is taken. The next we will move to what are the side effects that we can come across during growth hormone therapy in Turner syndrome. Dr. Somik, please, can you enlighten us?
Again, we know that there are certain common side effects of growth hormone therapy, and you can get all of them, but in Turner syndrome specifically, some side effects have been associated more common with growth hormone therapy. So these include benign intracranial hypertension, this include more scoliosis, this include disproportionate increase in size of the feet, this includes slipped capital femoral epiphysis, more of acute pancreatitis. Interestingly, there was also greater reports of type 1 diabetes following growth hormone, but this is more of an association rather than a cause-effect relationship. So some of the adverse effects that are known in others are possibly more exaggerated in Turner syndrome. And there could be some sort of facial disfigurement as well, greater dental malocclusion, facial disproportionation. So you need an orthodontic follow-up as well when you put Turner syndrome patients on growth hormone.
Yes. So as so Mika said, so it has got some side effects that can be observed, though it has been also said that I mean the
and I would
side
just
effects are
add
more or
for
less
exam purpose, if there's a student listening, they also say that since there are more melanocytic neva in Turner syndrome, they could grow in size with growth hormone therapy. Just for exam purpose to complete the answer.
Yeah, okay. So though it has been said that the side effects are not that more as compared to the other situations like other growth hormone deficiency where you are giving growth hormone, but however, as he has rightly said, some disproportionate disfigurement sort of that can occurs in terms of limbs and the face. Then I will move to Dr. Anna Bhattacharya. Can you enlighten us about what are the other extra skeletal benefits beyond the growth can be observed by giving growth hormone in Turner syndrome? Dr. Anna, please.
Yes. In fact, there are some studies which actually looked at body composition and metabolic effects, but there is no clear answer in this particular regard. Regarding the quality of life, again, it's not, I mean, it's expected that those who received growth hormone therapy, those Turner patients, should have, I mean, better quality of life at least. But it has been seen, interestingly, that in the decision, when the decision was taken and when the treatment was continued throughout the childhood and early adolescence, the patients who are on growth hormone therapy, they felt better. They said, yes, growth hormone is good, is doing good for us. But somehow when the studies were done in adults, there is one study, the largest study that has been done, there is actually no difference of quality of life between those patients who have received growth hormone versus those who did not. The possible explanation which was given is maybe the other factors like the issues with fertility, issues with body image, and other complications, cardiac, ear related or others. They possibly they reduced the quality of life scores and they possibly masked any benefit in this particular regard. But again, the treatment in I mean, for the other benefits is not that much. So possibly we should consider it the growth hormone therapy in Turner for height benefit only, not beyond that, unlike the Prader-Willi syndrome or something else that has been discussed.
Yes, you have rightly said. So it does not offer any other benefits in terms of other complications, maybe, or maybe the other metabolic parameters. Though sometimes the blood pressure and the lipid profile, as you have rightly said, the metabolic parameters may improve because of this growth hormone therapy. That is quite expected. Now I'll move to Dr. Subir. Can you enlighten us when to do thyroid function test in case of the Turner syndrome?
Actually, Turner syndrome is associated with autoimmune thyroiditis, and so hypothyroidism is common. And actually, if we monitor growth of child in Turner specific growth chart, if there is faltering on Turner specific chart, so we'll suspect whether there is secondary causes of growth failure like isolated growth hormone deficiency, hypothyroidism, or celiac disease. And I think every patient should also be treated for thyroid function test, and those who on growth hormone therapy, they should also be monitored with thyroid function test.
Yes, the important part is those even we know that the thyroid autoimmune thyroid hypothyroidism is common. Again, those who are not developing hypothyroid initially, but those who are on growth hormone, particularly one need to monitor thyroid function tests, say maybe 6 monthly or initially 3 to 6 monthly, so as to optimize the growth hormone effect of the growth hormone treatment. Now, I think.
So we should also regularly screen the Turner syndrome children from 4 years onwards. For 4 to 10 years, FT4 TSH and anti-TPO antibody, and again at 10 years or beyond, we should regularly screen for FT4 TSH anti-TPO antibody, according to guidelines.
As he has said, you need to monitor, and even also who are on growth hormone, probably you need to monitor more frequently to detect early development of hypothyroid and treat it so as to get the optimal benefit of the growth hormone treatment. Yes, so I think we have covered most of the aspect, but the other faculty like Partho, Anirban, if you are there in the board, so if you have any question, you can, I mean, you can participate.
Question to all the faculties. You all must agree that, for an example, if a girl presents at around 12, 13 years of age and having a Tanner stage B2, will you call me an idiot if I add a low dose estrogen along with a low dose oxandrolone? Low dose estrogen to promote the breast and the low dose oxandrolone to promote the growth.
May I answer?
Why not?
Yes.
Why not growth hormone first?
Yeah, because growth hormone is may not be available. It's a carry on.
Okay.
If the breast is already B2, that means there is sufficient estrogenation. The puberty is normal onset puberty, or puberty is there, and estrogen is in the pubertal level.
Maybe sometimes the arrest of puberty occurs.
What I try to say is that perhaps in a 13-year-old girl, a B2 probably is not appropriate.
Yes,
I do agree that the puberty has set in.
Yes.
At least there is some amount of estrogen. So.
Okay. My take is on that.
Okay. Yeah.
Partho, basically, what do you mean by low dose oxandrolone? Because you know the usual dose, although we don't have
the part
experience
is telling low dose estrogen plus oxandrolone.
I mean the recommended dose of oxandrolone.
Yes, but that is I would strongly oppose this because oxandrolone is known to have antagonistic action on breast when you consider estrogen action. So once you start estrogen, you should always take off oxandrolone. Now, there are two approaches if the Turner patient is severely short-statured. One is to add oxandrolone after the age of 10 years and do not give estradiol till the child is 12, and then you start estradiol. Second, if you don't have oxandrolone, then you can delay the puberty without giving estrogen for up to 14 years. And there are evidence. There is one very interesting study which actually looked at the difference of height gained by different approaches. Number one, oxandrolone plus GH. Number two, delay in puberty plus GH. And number three, the usual way, that is the GH with timely start of estradiol around 11 to 12 years of age. Now, it has been shown the gain of height in the two approaches that I have told, that is, one is oxandrolone and followed by estradiol from 12 years of age, and delaying puberty till 14 years of age without oxandrolone. These two groups have similar height benefit on an average, as far as I remember, around 4.5, 4.6 centimeter on top of in addition to the height that is gained by growth hormone alone. So I would not recommend the giving oxandrolone and estradiol together. No, if any other panelist and any other option.
If I could just complement exactly what Dr. Bhattacharya said, there is evidence that if necessary, in extreme cases, if there is puberty and you want to delay it, you can use a GnRH agonist. There is data, and you can increase the final height by about 4 centimeters. So you can delay it from, say, 12 years to 14 years at the most. There is data. And with oxandrolone and low-dose estradiol, the average height gain is just about 2 centimeters. So we actually do not gain a lot of height. And the concept of using them is to avoid puberty. So low-dose estradiol, oxandrolone would obviously be sort of an anti-puberty agent. It would delay breast maturation. And even low-dose estradiol, ultra-low-dose estradiol, which is used and can be used right from the age of 5 years, as early as 5 years of age, as per the study, it does not lead to premature puberty.
Yeah, as I mean, what is important is the oxandrolone, as it's androgenic. So it's, if you start simultaneously at the time of puberty initiation, that may, I mean, hinders the initiation of the puberty. That is important. And the studies, I mean, what Soumik is saying, the low dose estrogen can be started from as early as 5 years.
From 5, the study actually, they divided patients between 5 to 8 years, 8 to 12 years and above that. So 5 to 8 years was ultra low dose, 25 nanogram per kg per day. 8 to 12 was 50 nanogram per kg per day, and they gradually increased the dose after 12 years. There, the average height gain was just about 2 centimeters. There's a range, obviously. Some would gain more, some would gain less. And it's the same with oxandrolone. We'll begin it around 9 to 10 years of age and give it till 12 years. The average height gain is 2 centimeters.
Soumik, I beg to differ a bit. In oxandrolone, the height gain is around, as I've said, around 4.5 to 4.6. But with low-dose estrogen, there are some problem with the study design, as far as I remember, because the growth hormone that was given was not that optimal, because 3 times a week regimen was
exactly. It was a 3 times a week regimen.
That is not optimal. So we do not know whether on top of the standard growth hormone doses, whether addition of ultra low dose estradiol would help in height gain or not. That's not well known. But oxandrolone possibly has a better evidence.
The age was around 5 years of low dose, ultra low dose estradiol. You can begin it right from 5 years.
Once the FSH starts to go high, possibly theoretically, of course, because the actual cutoff is not increased.
Practical note, another, it's very difficult to get that dose of estradiol in clinical practice.
They have diluted.
The study actually formulated it from the laboratory. From the
exactly.
The ethanol base, they have formulated it. But again, it's a very controversial study by Ross et al. Ross et al. At NEGM. So it's a very controversial study.
Anything from the panelists can have any?
That was done with oxandrolone versus placebo only. And in that study, it was shown that the height gain is approximately, as Dr. Bhattacharya already said, that approximately 4 to 6 centimeters. So for this particular patient, I think oxandrolone alone might be helpful if growth hormone is not affordable.
So any of the panelists, panelists, also the faculties on board, if any issues, questions regarding Turner's, then we can discuss. Otherwise,
it's already 10 past 10.
Otherwise, I'll call it a day. So thank you, the panelists, our esteemed panelists. Thank you, our chairpersons, especially our respected Professor Chaudhary said, though probably he is not now in board, and Dr. Pranav Sahana, all the faculty, Dr. Anirban Sinha, all the faculties. And once again, thank you, Sun Pharma, for providing us the technical support. So thank you all, I think, and thank you audiences also for your participations. I think it's everybody has enjoyed this program, and thank you and good night.
Good night. Good night.
Thank you, sir. Thank you.
Night.
Thank you all the doctors,
Good night.
on behalf of
all
Sun
the
Pharma,
guest faculties.
Yeah, thank you, Animesh sir, for coordinating such a beautiful program.